Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical Notes and Lecture. So let's begin with the name of Almighty. The management of adrenal insufficiency. Okay, I said it can be acute or chronic. So first we'll discuss about acute adrenal insufficiency. So whenever a patient comes with acute adrenal crisis and you suspect a patient with acute adrenal crisis depending upon the BP, heart rate, electrolyte abnormalities, then immediate actions within minutes is take two large bore IV, secure two large bore IV cannulas, give hydrocortisone 100 mg IV bolus, then 50 mg IV every 6 hourly. Alternatively, you can also give dexamethasone 4 mg IV if diagnostic testing is pending. Why doesn't the important point here is doesn't affect the cortisol assay but does not have mineralocorticoid activity. They need to give IV fluids, NS 1 liter over first hour, and then titrate to hemodynamics. Then dextrose if you also see hypoglycemia in the patient. Correction of hyperkalemia is rarely needed. Why? Because steroids and fluids itself will decrease the concentration of osmolarity of potassium. And treat the recipient, and most often the common cause is sepsis, so give empiric antibiotics if you suspect sepsis. And one more thing is no need for mineralocorticoid uh, in acute cases. This high dose cortisone has sufficient mineralocorticoid activity. Okay, so hydrocortisone you should give, IV fluids, dextrose, okay, and antibiotics. So that's how you manage. Key points are: do not delay steroids for tests. Early fluids plus steroids save lives. Monitor what? BP, pulse, urine output, electrolytes, and glucose. Common precipitants. Infection is the most common, I said. Surgery or trauma. Gastroenteritis. Okay. Vomiting and diarrhea. Missed or inadequate steroid doses. Severe physical or emotional stress. So these five are common precipitants. Okay. Any stressful situation can precipitate acute renal crisis, most common being the sepsis or infection. Then after you stabilize the patient, then comes the chronic maintenance therapy, or if a patient is diagnosed with chronic AI, then this is the therapy. Hydrocortisone can be given, prednisolone can be given. So one can choose either hydrocortisone or prednisolone orally. Hydrocortisone is given as 15 to 20 mg per day. 2/3 of the dose is given morning and 1/3 of the dose is given afternoon. This mimics the circadian rhythm. This is first line glucocorticoid treatment. For example, if the patient is given, for example, 24 milligram per percent, then 16 mg hydrocortisone should be given in the morning and 80 mg should be given in the afternoon dose. Okay, afternoon dose. Then the most practical way to for chronic maintenance therapy is giving prednisolone. Okay, this is given as 3 to 5 mg per day, once daily in the morning. This is an alternative, longer acting but better compliance. Patient has better compliance. So this is adrenocorticoids. Then coming to the mineralocorticoid replacement, that is fludrocortisone, can be given at 0.05 to 0.2 mg per day. So this is given only in primary AI. Okay. Then the dose of fludrocortisone is titrated according to the BP, the potassium levels, and the renin levels. So this is not needed in secondary AI. So, and the most common is secondary AI only. Then comes the sex steroids. So this is sex steroids, replacement of sex steroids. This is mineralocorticoids and this is corticosteroids or adrenocorticoids. Okay, this is dehydroxyepiandrosterone. So 25 to 50 mg per day is given. This is considered in women with low libido or mood despite optimal replacement. Dosing principles. So the lowest effective dose should be given. Avoid Cushing-White features from over replacement. So there is a risk of osteoporosis, weight gain, and glucose intolerance. Under replacement, will cause fatigue, weight loss, hyperpigmentation reoccurs in case of primary. That's about the second point in management of AI. Then we should have something called a sick day or peri-operative stress dosing in patients with AI. So that can be in the form of minor illness or fever, vomiting or diarrhea, minor surgery or procedure, major surgery, trauma or ICU, emergency. So in minor illness or fever, patient should be counseled to double or triple the usual oral dose for 2 to 3 days. 3 days. Okay. In vomiting and diarrhea, give 100 mg either IM or IV hydrocortisone. Okay. Stat. Minor surgery, give hydrocortisone at 25 to 50 mg IV at induction. And in major surgery, give 50 to 100 mg IV every 6 to 8 hourly and taper over 24 to 72 hours as stress resolves. So major surgery you need to give it as a replacement dose. Minor surgery just give induction dose, that's all. Emergency, patient carried emergency injection kit like 100 mg IM hydrocortisone plus medic alert card. Okay, when the patient is unable to swallow. Okay, that's how the replacement dose began. That is known as sick day rules, similar to the sick day rules of diabetes mellitus. Okay, then how do you monitor and follow up the patient? So what we will see in monitoring, we see clinical labs, okay, bone density, autoimmune screening, okay, these things we see. In clinical, weight of the patient should be checked, BP both supine and standing should be checked, okay, energy should be checked, skin pigmentation should be checked, signs of over and under replacement as explained in the previous slide should be checked. And in labs, and in the most important we can take here is these two, weight and BP of the patient, and signs of over and under replacement. Labs, sodium important, potassium, renin and aldosterone for fludrocortisone titration in case of primary AI or Addison's disease. And not serial cortisol. So serial cortisol levels should not be used for monitoring and for follow-up because patient is already on replacement, and that's why this is meaningless. Bone density, DEXA if long-term steroid use. Autoimmune screening, annual screening, yearly screening for associated autoimmune conditions like thyroid, type 1 diabetes mellitus, premature ovarian failure, and celiac disease. Four things: thyroid, type 1 diabetes mellitus, celiac disease, and premature ovarian failure. If autoimmune primary AI is there, then the patient should be screened yearly for this. Ensure the patient has medical alert bracelet or card plus emergency hydrocortisone injection kit at all times. Okay, this is how you monitor and follow up the patient. Contraindications or cautions which should be taken in these patients. Avoid abrupt withdrawal of exogenous long-term steroids. So any a dose of prednisolone more than 7.5 mg for more than 3 weeks is long term. More than 7.5 for more than 3 weeks is considered as long term. Okay, so avoid abrupt withdrawal of exogenous long term steroids more than 3 weeks. Superphysiological, taper gradually. So any patient who receives for more than 3 weeks now, then we should taper it gradually because the HPA axis. So what the thing which happens with exogenous steroids is actually hypothalamus hypothalamus will sense these exogenous steroids and will decrease the secretion of corticotropin releasing hormone, and our body becomes dependent upon these steroids. So and it will take years or months to recover. That is very bad problem. Okay, if we give exogenous steroids, hypothalamus is affected. So drugs like ketoconazole, etomidate, so this is an induction agent in anesthesia. Metotane is actually a it causes necrosis of adrenal gland. So used in adrenal hyperplasia or adrenal carcinoma when surgery is not appropriate for any patient. So this can precipitate or worsen AI. That's why they should be used cautiously. This is very important point. Levothyroxine, if the levothyroxine is started before hydrocortisone, what happens? The remnant steroid which is present, remnant cortisol which is present, that will be cleared from the body and patient will go into adrenal insufficiency. That's why always give hydrocortisone before giving levothyroxine. That is very important. Diagnostic cortisol or SCATH testing is invalid if patient is already on exogenous steroids, except dexamethasone during acute testing. Okay, except dexamethasone during acute testing. So this testing cortisol SCTH is invalid if the patient is already on exogenous steroids. So patient should quit it for 2 to 3 days actually. 2 to 3 days, and then when we can check this one. Do not withhold empiric steroids while awaiting confirmatory testing in a hemodynamic unstable patient. So these are the cautions. So abrupt withdrawal should not be done, and this one your these drugs and levothyroxine replacement and cortisol ACTH testing and empiric steroids. Okay. What are the complications? So complications, if one is untreated or if the patient is undiagnosed, patient can uh, go into adrenal crisis that can lead to shock or death. Patient can go into recurrent hospitalization because of inappropriate dosages. Because of decreased sodium, patient can have hyponatremic seizures. Because of increased potassium, patient can have arrhythmias. Okay, this is the risk of adrenal crisis. Over treatment, patient can have iatrogenic Cushing syndrome, risk of osteoporosis and fracture, weight gain and glucose intolerance, and increased cardiovascular risk. 4 over treatment things and 4 under treatment things. Okay, Cushing out status, osteoporosis, weight gain, increased cardiovascular risk. Okay, prognosis. With appropriate replacement plus patient education, there is near normal life expectancy. Mortality mainly from undiagnosed crisis or inadequate stress dosing during intercurrent illness. Very important. So during intercurrent illness, they use the same dose and they land up with AI crisis. Okay, or the patient is undiagnosed crisis and they have some precipitant that will land up with AI. So that is associated with high mortality. Studies show AI patients still have higher mortality, mainly cardiovascular and infection related than general population, even on treatment, likely due to non-physiological cortisol replacement patterns and underdosing during stress. Quality of life often reduced despite adequate biochemical replacement. Imperfect circadian mimicry. So there are total 9 pitfalls in adrenal insufficiency. What are those? Number 1, waiting for cortisol or ACTH results before treating suspected crisis. Treat first, confirm later. Number 2, missing secondary AI because there is no hyperpigmentation and normal potassium. These findings are expected to be absent in secondary AI. Forgetting to ask about chronic steroid use. It can be inhaled in the form of inhaler, it can be topical for skin conditions, it can be intraarticular for musculoskeletal conditions like osteoarthritis, it can be in the form of herbal preparations, very commonly used, and I, I counsel my patients that if in herbal patients they use a lot of steroids, steroids. Okay, so this is the most common cause of secondary or tertiary adrenal insufficiency. Forgetting to ask about chronic steroid use. So, fourth pitfall, starting levothyroxine before hydrocortisone in combined hypothyroidism. So, it can land up with AI. Always start hydrocortisone first. Not educating patient on sick day rules can lead to preventable crisis. And over reliance on random cortisol in critically ill patients. Because the albumin is decreased in critically ill patients, so altered protein binding hypoalbuminemia falsely lowers total cortisol. So in critically ill patients, don't rely upon random cortisol. See the electrolyte levels, see the BP, see the heart rate, see sodium, potassium, pigmentation, these things. Giving fluorocortisone in secondary AA not needed because aldosterone is intact. Missing tuberculosis as a cause in endemic regions, example in India, it can be pulmonary tuberculosis. Always image adrenals and consider anti-tuberculosis workup. Not screening for associated autoimmune disease in primary autoimmune AI. Thyroid disorders and type 1 diabetes mellitus, celiac disease are very commonly associated with this primary AI. Okay, these are all the 9 pitfalls of adrenal insufficiency. Now coming to special context. So pregnancy, first special context. Hydrocortisone dose may need 20 to 40% in third trimester. Stress dose for labor and delivery. Avoid dexamethasone in pregnancy. Why? Because it crosses the placenta and stress doses required during labor or delivery. Second is critical illness, sepsis or ICU. There is, even though they don't have AI, but they have a relative of functional AI. So the treatment is controversial. Consider hydrocortisone 200 mg per day in septic shock refractory to fluids and vasopressors, as per surviving sepsis campaign, regardless of the cortisol. In surgery, okay, stress dose steroids based on surgical severity. Minor surgery 25 to 50 mg every 8th hourly, they should be given for 24 hours. And moderate surgery 50 mg at induction and then 25 mg every 8th hourly. Major surgery 100 mg at induction and 50 mg every 8th hourly for 3 days. Resume oral once tolerating. In pediatrics, congenital adrenal hyperplasia should not be missed. 21 hydroxylase deficiency, which is a leading cause in pediatrics. Okay, and there is a weight-based dosing. Hydrocortisone 8 to 10 mg per meter square per day. HIV/AIDS, common cause of, and tuberculosis. HIV/AIDS and tuberculosis is a common cause of this AI in developing countries like India. So cytomegalovirus, adrenalitis, and ketoconazole rifampin drug interactions affecting steroid metabolism. TB is a major cause of primary AI. Screen and treat. Drug interactions with rifampicin induces cortisol metabolism, may unmark or worsen AI. Increase hydrocortisone dose in patients who are treated with anti-tuberculosis drugs, which has rifampicin, because rifampicin accelerates the metabolism of cortisol. Checkpoint inhibitor therapy. Immune-related hypophysitis, inflammation of the pituitary, that can lead to secondary AI. This point should be remembered. Okay, so can be delayed onset. High index of suspicion in patients on immunotherapy with fatigue and hypotension. Immunotherapy patients with fatigue and hypotension. And elderly, it can present as atypical presentation, and there is a high fracture risk with over replacement. Use the lowest effective dose. Okay, so pregnancy requires increase in the dosage up to 40% and stress dose at labor or delivery. Avoid dexamethasone in pregnancy because it crosses the placenta. Critical illness, shock which is not responsive, you can consider giving hydrocortisone. Surgery, again, stress dose should be given. Pediatrics, consider congenital adult hyperplasia. HIV/AIDS and India, tuberculosis should be considered in developing countries. Cytomegalovirus, adrenalitis, and ketoconazole and rifampicin drugs interaction should be considered. Checkpoint inhibitor therapy. So what this will do, this can cause inflammation of pituitary and can lead to secondary AI. Elderly, they have atypical presentation. Quick reference, the takeaway. Suspect AI if there is unexplained shock or hypotension with hyponatremia, with hyperkalemia, with hypoglycemia, hyperpigmentation in primary, or known steroid use or pituitary disease in secondary. How do you manage the crisis? Draw cortisol plus ACTS, save the sample, don't wait for results. Give hydrocortisone 100 mg IV stat 50 mg IV every 6 hourly. NS bolus, correct the hyperglycemia, treat the precipitant. Mineralocorticoid not needed acutely because high dose HC covers it. Then once stable, or if a patient is coming with chronic AI, confirm with AM cortisol. If it is less than 3 microgram per deciliter, then it is diagnostic. And if the AM cortisol is more than 15 microgram, then AI is ruled out. Adrenal insufficiency is ruled out. And if the AM cortisol is in between 3 to 15 microgram, then it is known as indeterminate, and it requires a confirmatory test, and that is cosyntropin test. So in cosyntropin test, I said 250 mg of cosyntropin, meaning ACTH is given, and the samples are taken at 1 and 2 hours. So if the cortisol level is less than 18, then AI is confirmed, and if it is more than 18, then AI is ruled out. Then localize whether it is primary or secondary. You can do that by ACTH level and potassium level. Increased ACTH and hyperkalemia says it is primary. Decreased on more normal ACTH, normal potassium says it is as secondary. Maintenance requires hydrocortisone or prednisolone. Okay, split. It should be split. Prednisone should be given once daily. Fludrocortisone is required only in primary cases. 0.05 to 0.2 mg per day, titrated according to renin and aldosterone levels. Always counsel about sick day rules, emergency intramuscular kit, medical alert card, and treat AI before giving thyroxine. Okay, that's all about adrenal insufficiency. Thank you. In the next video, we will discuss about a practical case of adrenal insufficiency which we come across our daily life. Thank you.